Welcome to the Feel Better, Live Better podcast. Our goal is to provide you insightful conversations about all things health and wellness. We dive into the stories, science, strategies that help you optimize your well-being, physically, mental, and emotional health. Each episode features engaging discussions with health experts, real-life success stories, and practical advice to empower you on your wellness journey. Whether we're breaking down the latest medical advancements, exploring holistic health solutions, or chatting about everyday habits that make a difference, our goal is simple: to help you feel better and live better. Tune in for inspiring narratives, expert consultations, candid conversations that bring health to life, one talk at a time.
If you enjoy our podcast, please like and subscribe and consider becoming a digital subscriber to the Albuquerque Journal to help us bring you more content like this. You can find this episode and all of our podcasts on the Albuquerque Journal website, abqjournal.com, as well as YouTube, iTunes, and Spotify. See the show notes for a discount code on a digital subscription. Thank you for supporting the Albuquerque Journal, New Mexico's leading news.
Hi there, I'm Kristi Furry, and welcome to Feel Better, Live Better. This is part one of a special 3-part series where I'm sitting down with my good friend and fellow nurse practitioner, Mary Ann Butler, to explore what it really means to age well. Today, we are talking about hormones, the foundation of health. Whether it's energy, mood, sleep, low libido, or metabolism, our hormones are the center of it all. In this episode, Mary Ann and I break down the myths, talk about hormone therapy, and explain why optimizing your hormones might be one of the most powerful things you can do for your long-term health. Let's get into it.
Beyond Health is dedicated to helping patients achieve a life of health. Our passion at Beyond Health is transforming your health so you can live the very best life. Beyond Health can be your partner in your journey to optimal health.
I'm so excited for the guest today, Mary Ann Butler, who's been a very dear friend of mine, a colleague friend for many years. So welcome to the show, Mary Ann.
Thank you. I'm so glad to be here, and I'm honored that you asked me to come.
Of course. So today I would like to talk about hormones. And the first question is, let's address some of the misconceptions and myths surrounding hormone therapy for today.
Yes. So I think this is a most exciting time to be in the hormone space. And, you know, as you and I have talked about before, we feel like this is a specialty. And there's been so much misinformation after the Women's World Health Initiative. And then on the men's side, it's also been, you know, that testosterone causes prostate cancer, et cetera, things like that. So now it's becoming more publicized, I guess, with the FDA panel and things like that, we may have had it wrong. And you and I have known this, right? That the hormones that we are using are natural hormones. And there's a difference between the natural hormones that are bioidentical to your own hormones that God gave you and the hormones that are synthetic made that kind of trick the body into thinking you have that hormone, right? And so some of those synthetics can actually cause harm, whereas the naturals don't cause harm. And people don't know. They're just not aware.
Yeah. So I think let's dive a little bit deeper, just so the audience can understand how big of this new FDA ruling that just recently came out. What was it, July 17th?
Something like that.
As far as basically removing the black box warnings off of hormones. So because I think that's so important, because I know clinics like yours and mine, we've been fighting this uphill battle against hormones. And we have always known the type of hormones, to your point, the bioidenticals versus synthetic, what we were giving is safe. But I would like to know your input, and let's explain to our viewers what that recent FDA ruling, what that means to us as a society.
Right. So what we know is that as we age and our hormones decline, that we are at higher risk for cardiovascular disease, prostate cancer, breast cancer, obesity, diabetes, increased visceral fat, all of these things that, we've always kind of considered them to be just parts of aging, right? Well, they're not always parts of aging. A lot of it has to do with this drop in your hormone levels. So whenever we talk about the black box warning and what has been said that, hormones cause blood clots, strokes, heart attacks, prostate cancer, breast cancer, people don't want to take that.
Yep.
Right? They're afraid. And your doctor says, oh, no, you should not take that. That's bad for you. Or the doctor that actually knows will give them a prescription and they get home with this prescription. And this came out on the FDA panel, and I was so excited to hear this doctor say so. They look at that black box warning and they, oh my gosh, I can't take this, and they throw it in the trash, right? So now what is happening to their health as they age? It's deteriorating. So people they don't know really what to believe. And so removing that black box warning, now when their doctor says, I think that this is time, we need to put you on these hormones, this would be for your benefit, that they can go home and look at that label and go, oh, yeah, okay, this is how I take it. Yeah. And they'll take it.
Yeah. So that Women's Health Initiative that came out in 2001, right? I think it was right. So the only arm of that study that, as you and I know, that showed cancer was the progestin arm. However, the whole study was stopped, right? They decided there's too many risk factors. But then when they really looked back, and then the researchers that did those studies in 2017 came back and said, look, we got this wrong. We should have continued that other arm of the study of women that were getting progesterone, estrogen, or the estradiol, and the testosterone, because there was actually a decrease in breast cancer, cardiovascular disease. So explain to our viewers a little bit more about what that progestin is, which is a hormone you and I have never used, will never use for patients.
Correct. Yes. So the confusion came in whenever Provera, they named that drug medroxyprogesterone. Yeah. So unfortunately, a lot of times they classify drugs and then they lump all the negatives, positives, everything all into one, right? And they just make it a blanket statement. And in this particular case, what we call micronized natural progesterone, which is, again, human identical or bioidentical, some people want to refer to, that is natural for your body, and your body sees it as your own natural hormone that you're replacing. Progestin, which is a medroxyprogesterone, which is a synthetic progesterone, it does not act the same way in the body. Yes, it can take care of some of the same symptoms that progesterone takes care of, but it does not, the body doesn't look at it the same. It's a foreign invader, right? So some women will have some pretty, adverse effects. It makes them feel bad. It makes them feel worse than they were before, more bloated, things like that. Some don't have those symptoms, but they don't know that particular progestin is the one in the World Health Initiative arm that caused a lot of the ruckus.
Yeah. So let's move on as far as the role of hormones in aging. So let's discuss what are some symptoms that, let's start with men. What are some symptoms that men will start noticing when their hormones are declining?
Yes. So, everyone's a little bit different, but usually the very first symptom is fatigue. And when you have a lot of our patients are, they're just high energy, they're active, they're project minded, so they just think, well, this is just part of aging. I just had to bull my way through it. My husband was like that, but he went from, coming home from work and then going outside and always having a project to coming home and just sitting on the couch. And then having to peel himself off the couch because he knew he had these things to do, right? So usually it's fatigue is the first one. And then, but men won't come in for that.
No.
They'll come in whenever their sex life is not working, right?
Yeah.
That's really when they start saying, I got to do something, right? Yeah. So, and fortunately they do, because, then there's some who just simply, unfortunately, move into a platonic relationship, because their wife probably needs hormones too, but the two of them are kind of on the same pace. And so they just think, well, this is just part of our
part of life.
This is part of life. We're getting older, we just don't do that anymore. It is an important part of a relationship and a marriage, right? So, but for those men that, recognize that, hey, this is kind of early for me. I'm not ready to give up my sex life, that will bring them in. So fatigue, erectile dysfunction, or a lack of libido, lack of sex drive, those kinds of things. Yes, sleep is a big one, but they don't always equate sleep with their hormones. They just figure, I just got a lot on my mind, or, whatever. There's other excuses and rationale. But what they find out whenever we start optimizing their testosterone, they're like, oh my gosh, I sleep better. I sleep better. I manage my stress better. I just feel better. I don't get so irritable. That's another thing. They get irritable. But then again, they don't associate that with their
decline. And I think what I've noticed also in the clinic is, I know you and I have a very similar practice in the sense of most of our patients are pretty like-minded, and most of them have some form of exercise in their life, right?
Yes.
And so I get a lot of men of like, I'm just not getting the same results in the gym, or my strength has gone down. Because as you know, and I, as far as, muscle loss is a hallmark of aging.
Yes.
So let's dive a little bit deeper from a cellular perspective. So what does optimized testosterone in the male body do?
What we know about testosterone, it aromatizes into estradiol. So a lot of the benefits that we know of testosterone are actually estradiol, which is why it's so important not to block your estradiol ever. And so what we're talking about is that, and I read a study, which was so exciting to me, and it was an in vitro, meaning that, it wasn't in a human, it was in a, like a dish, right? But what they saw is that estrogen, as well as progesterone, but men, we don't use progesterone, that estrogen will break up the fibrocardioblast, right? So testosterone, estrogen is good for your heart, right? So it improves your cardiovascular health. It helps to reduce the formation of hard plaque. So now we're talking about improved brain, blood flow to the brain, blood flow to the heart, blood flow to the sex organs, so you have better function. And then it's also very important for the prostate. Right. So testosterone, again, aromatizing into estradiol, is very protective for the prostate. We know that men with, the studies have shown us, men with higher testosterone levels have a lower risk for prostate cancer. As that testosterone drops, and especially if it gets below 200, they're at a much higher risk
because of that.
Yes, and even the ones who do, unfortunately, develop prostate cancer have much better outcomes if their testosterone levels were higher.
Well, and I think, and most urologists are on board with this, but as you and I know, testosterone does not cause prostate cancer. I mean, and like I said, I've been doing hormones since 2014, and I think you were around the same. When did you start?
2017.
So about the same time. And, at first there was a little bit of still that gray area with the testosterone and prostate, but now it is very clear.
Yes. We have to give credit to Dr. Abraham Morgentaler because he has really, pulled the literature and researched it. And as a professor, he's had his students that he would tell them that, at the beginning of the semester, he says, you find me the research, the literature that shows that testosterone causes prostate cancer, and have it in this box by the end of the semester. And the box would be empty at the end of the semester. That's what it.
Well, and I think, I have a few men in my practice right now that have prostate cancer, and their urologist is actually on board with them still getting testosterone.
That's awesome.
And, it's been a breath of fresh air. So let's move to the female patient. When you have a patient, and let's talk age too, because I think that's important, especially with this, FDA statement that came out that the earlier females start hormone replacement therapy, the better off they're going to be from osteoporosis, sarcopenia as far as muscle loss, cognitive decline, and breast cancer. So, like, when you have a female patient that comes to you in her 30s, and then we can move 40s, 50s. Sure. But like, what is the symptom that you see clinically most them coming to you for?
Yeah.
When they know something's not right.
Something's not right. Yeah. So around 25, right, is when testosterone secretion from the ovary starts to drop off, right? And then usually they still have a pretty good progesterone, but unfortunately, I think endocrine disrupting chemicals, those kinds of lifestyle choices, not being heavy, not being healthy eating, pregnancy, things like that, we'll see progesterone start to drop off. Yeah. And what they come in with is, I just don't feel good. Yeah. My periods are real heavy, or I'm irregular. I have no sex drive, so that's usually when I'm looking at that 30-year-old. For one, I'm looking for PCOS, which is insulin resistance disorder, right? Because it's more common than we ever knew before or recognized before. And so, I'm looking at their thyroid levels. I'm looking at their insulin levels. What are their lifestyle choices and things like that. And we just start addressing those things. Women in their 30s generally are producing plenty of estrogen, and we're not going to give those women estrogen.
Absolutely not. Yeah. So then how about 40, 50s?
So 40s is when we really do see more drops in progesterone. I'm not sleeping. I'm irritable. I'm crabby. I don't have a sex life, those
I hate
kinds
my
of
husband.
things.
I hate my partner.
And oh my gosh, it's so sad because, it'll be like, I love him and I want to make him happy, but I just do it just because I have to
do it. Yeah.
And nobody wants to feel that way. No one wants to, you want to enjoy your husband and your relationship and your children and your activities and things like that. And so I will start them on a micronized progesterone, usually at a lower dose than say one that's closer to menopause or full menopause. And again, looking at their thyroid, making sure their thyroid is optimized. And then we address gut issues and things like that. But generally every one of them gets put on some kind of testosterone. Yes, because testosterone does so many good things for women in the in the body. It just improves your metabolism. It improves your bone density. It improves your motivation and your overall mood and things like that. And then as a nice perk, it also increases your sex drive.
Right.
So,
and I think that's so important because so many women, especially if they come in completely naive, like they don't have much knowledge, they're kind of blown away when I say, this is your testosterone level. And they're like, well, I thought that was a male hormone. So why do you think to our viewers, where do you think the misconception of that started occurring?
Well, because when we talk about hormones and we talk about testosterone, it's always in regards to men, right? I mean, it's never in regards to women. And like I said, PCOS, right, which is always kind of gone just sort of dismissed. Nobody really knew. Is it a gynecological issue? Is it an endocrinology issue? Nobody knows. Yeah, we know now. Yeah. But those would be the only women who had high testosterone levels, right?
Correct.
And so it was a disorder. So from a practitioner's perspective, it was like, well, if they have high testosterone, that's a disorder, right? And we certainly don't want to give them a disorder, which is another misconception that we're muddling through, is that when you give a person, man or woman, a hormone, it doesn't mean you're going to cause them to have a disorder, right? Yeah. So, but it was just never recognized. And I have to be honest, I did not learn that women produced testosterone when I was going to school and when I was in college. I just didn't know. So it was like, oh, really? Yeah.
Well, I think, for myself, I have to actually thank my orthopedic surgeon. Let me see, when did I had my hip surgery? I think I was 30. Have had a labral tear, an impingement, and have the nylon brackets in now, and was dealing with just a lot of inflammation, more so self-induced because I went back to work too early. And it was actually, my orthopedic surgeon handed me this article, and he says, Kristi, look at this article. It's something about testosterone and anti-inflammatory. He's like, see if you want to do it. I'm like, okay. So I literally read it, and I was like, huh. And I just started with creams. And that was in my, I can't remember, 32 or somewhere around there. And holy cow, I didn't have to go down that prescription route of anti-inflammatories. And, at the time they weren't doing so much PRP. It was, that was way back 2010. But I can just tell you even what just a cream did for me. And that's how I started. I started with creams, went to a provider. And then as I entered this world, when I left the hospitalist world and came to private practice, that's really when I started dabbling with orals and then now the pellets and even injections. So let's circle back around. I want to make sure our female viewers really understand how important estradiol and progesterone is in the roles of menopause. Because, I think if you and I could do anything for our patients as far as getting that message across, but nothing kills me more when I have a female that comes in that, you and I sadly see it more often than not, where, that brain fog is already setting in, that muscle loss is setting in. Although they're not sick yet, you and I see a sick patient, right? So I really want our female viewers to know how important and what does estradiol and progesterone do for us.
Yes. So, yeah.
And we can break it down.
I appreciate some of the literature that's out there. Dr. Avram Blooming, he has gone through and put in his book, Estrogen Matters. Yes, the importance of estrogen, but the 50 years of study prior to the World Health Initiative that show that estrogen is extremely important for, like you mentioned before, our bones, right? It is like the strongest next to growth hormone in the body, right? It is also neuroprotective and neuroplastic, meaning that it helps to protect the neurons in the brain as well as improve synapses in the brain. So, when we talk about cognitive function, it's important for that, but it's very important for the breast. Women think that, I can't do estrogen because my mother had breast cancer or breast cancer in our family. Yes, you can. Estrogen has been shown that the studies have shown that women on HRT have lower risk for breast cancer. And in Dr. Blooming's book, he points out that the studies also show that estrogen doesn't cause breast cancer. It doesn't cause recurrence. So in women who had breast cancer, there's no recurrence of breast cancer. And I think this is extremely important for women so that they feel comfortable, knowing that they're doing something good for themselves. But we're talking about, you're preserving your bone, you're preserving your brain, you're preserving your breast. It improves visceral fat, so you're decreasing, because women don't realize, it's like, oh my gosh, where did this stuff in the middle come from? Like, I never had that before. Well, as your estrogen drops, you start to produce more visceral fat. And it's actually that visceral fat that puts off an inflammatory cytokine and estrone, which can stimulate aromatase in the breast tissue. So really, when it comes to estrogen, which one's the cause of breast cancer? Visceral fat. Right, exactly. So I think it's important that they understand that, yes, the earlier you begin to replace those hormones, then not only are you going to feel better, have less vaginal. Well, that's another thing. There's on that FDA panel, one of the doctors talked about her, she's a gynecologist, her population of women coming in with vaginal dryness and recurrent UTIs and, bladder issues and things like that. Estrogen protects all of those things.
When all these women were getting all these unnecessary surgeries when all they needed. How many times have you and I fixed urinary incontinence, dry, any kind of bladder issue with just giving them estrogen.
Yes, exactly. Just giving them estrogen decreases their recurrence of UTIs, flourishes the moisture in the vaginal vault, so, it decreases all that dryness and everything, and it balances out the pH. Yeah, it's really, and then progesterone. Progesterone is very protective for the breast. So unfortunately, there's still a large body of providers that think that if a woman has had a hysterectomy, she doesn't need progesterone.
Yes.
Or they don't understand the difference between medroxyprogesterone and our natural progesterone. But no, even if you don't have it, you need it to protect your breast. So,
Well, and I tell patients, we have hormone receptors in every tissue in our body. Just because you don't have a uterus, it doesn't, you have progesterone in your heart, breast tissue, brain. You have progesterone everywhere, right?
Yes, exactly.
So you still need progesterone even though you have you've had a hysterectomy.
Exactly.
And then I even argue, or I shouldn't say argue, but women that come in with the Mirena IUD, well, they're like, my other provider told me I don't need to be on this progesterone because I'm getting progesterone from my Mirena. And again, as you and I both know, that's just uterine progesterone. It's not going to every other organ.
Exactly.
So I think we've talked on, so let's talk about the health span, that if hormones are started earlier for both men and women, how it truly can help a patient have true health and have a longer lifespan.
Yeah. So I want to kind of really focus on the muscle and the anti-inflammatory benefits of testosterone, as well as even estradiol in preserving that muscle. As we age, I heard someone say, muscle is currency. I love that because it is so important in reducing inflammation, supporting your joints, right? Reducing visceral fat, things like that. So when you have more muscle and less inflammation as you age, then you're gonna age better. You're gonna stay more mobile, and that's what we want people to move, right? Yeah. You're gonna stay more mobile. If you stay more mobile, you're going to be motivated to eat better. Yeah. Because it's like if you can't get yourself off the couch, a bag of chips. That's not right. Kind of thing. So, exactly. So just starting there. And then like we've talked about with estradiol, knowing the benefits of estradiol and how it reduces visceral fat and it improves bone mineral density and cardiovascular health and brain health and things like that. It is just, why wouldn't you want to do it? Why wouldn't you want to age well? Yeah. Because you've spent your whole life working. You've saved up all of your, retirement to do what? Pay to go to the doctor every 3 months and have your, labs drawn and buy all these prescription drugs that just patch problems that were avoidable.
Yeah. Well, and I think, I tell patients, I can't stop you from aging, but hormones can help you age to a younger self.
Yes.
Right?
Yes.
So in wrapping up, I think this has been very informative, but if there was something that you could leave the listeners with as far as understanding about hormone health, what might that message be?
Well, I would say do your research because the information is out there, and research isn't on TikTok. Correct. It's not on social media, even though we'll be on social media. But if you hear somebody say something, then go ahead and do the research or find a knowledgeable practitioner who has spent time. I have certification. You have certification in hormone replacement therapy, who has spent time studying and knows the literature, and let that practitioner guide you, because this is an important aspect of your health. And as we've talked about, improving your health span so that you can stay healthier as you age.
Well, and I think for my patients, so 2 books that I give out on a regular basis is our good friend, Dr. Terry Denai's book, The Hormone Havoc, because I think she does a phenomenal job really going over the myths and misconceptions, but yet has the literature supported.
Yes.
And then I do give out that Estrogen Matters book. I'm drawing a blank on Dr. Rousier's.
Normal is not optimal.
Normal is not, yes. So
Which is
that
what-
is a fabulous, normal is not optimal.
Right, exactly.
Yeah.
Which is an important thing, just real quickly, is that when that practitioner should be able to read your labs, not according to what the ranges say, but according to what they know based on the literature, what is optimal for you. Because those ranges are not scientifically designed for what's in your best health, right? They're simply a data set of the population, and we know that our health has declined over the last 20, 30 years. So it's like we tell people, well, you're in the middle of the range of old, tired, sick people.
Yeah.
Is that where you want to be?
Is that where you want to be? No. Well, thank you again. I think this has been very enlightening for our viewers and for myself. And thanks, Mary Ann.
Yes, thank you. Thank you. Glad to be here.